I have also told my wife that if I ever find myself on the brink of a breakdown in the mental realm, she is to send me to Silver Hill. So, how do you treat people who don't meet the danger to self or others threshold but are still unraveling? Like in my worst nightmare, I imagine a level of burnout that no amount of vacation allows me to come back from. This is We Need to Talk with Dr. Darcy Sterling, where I give you the tools and the skills you need to love better so you can live better. When the media talks about inpatient psychiatric treatment, the narrative almost always centers on forced hospitalizations, unhoused people, and violations on civil liberties. What is missing from that conversation is a very different reality, one that I have witnessed up close for years as a clinician. There are times when weekly therapy, even if you're going multiple times a week, just isn't enough. Times when even the most high-functioning, therapy-savvy, and well-resourced people hit a wall and need a level of structure and support that outpatient care simply cannot provide. But our mental health system is designed to respond to emergencies, not to prevent them. If you're a danger to yourself or someone else, there are places to go. But what if you're not suicidal or homicidal, just falling apart? What if you can feel it coming and you want to get help before you get there? We have a gap in mental health services. There are very few places someone can go ahead of time, even when the warning signs are glaring. It is a gap that today's guest knows about and one that his hospital is trying to fill, not just stabilizing people in crisis, but proactively supporting them through deep, sustainable change. Today, I'm joined by Dr. Andrew Gerber, President and Medical Director of Silver Hill Hospital. He is a psychiatrist, a researcher, and a thought leader who has spent his career building systems of care that are both rigorous and compassionate. We are pulling back the curtain on what inpatient care really looks like when it is elective, voluntary, and tailored to people who want help, not because they've been forced into it, but because they're ready for it. If you've ever wondered whether inpatient treatment could be the right next step for you or for someone you love, this episode is for you. Let's start with the obvious. What do people think inpatient psychiatric treatment looks like, and what does it actually look like specifically at Silver Hill?
So I think there are a few different misconceptions about this term inpatient psychiatry, and they come from a few different places. So let me start with, in some ways, the most obvious one. I think people, unfortunately, still have an image of inpatient psychiatry as conjuring up some scary, non-therapeutic space. Maybe this comes from an old movie. Maybe this comes even from One Flew Over the Cuckoo's Nest, or from some other movie that portrayed something that I'm not going to say never happened, because those things did happen. And sadly, there are even maybe some examples of it happening today. But most inpatient psychiatry, certainly the inpatient psychiatry we have here at Silver Hill, is not scary. It's therapeutic. It's a place where people get better, and we work really, really hard to create such a space. So that's one area, and we can get way more into the details if you want about what I mean by a therapeutic space and how things have improved, particularly in an environment like Silver Hill over the years. But I think the other way that people can misunderstand this term inpatient is, if you go back, in the grand scheme of things, not that long, let's say 20 or 30 years, there was a huge range in what people meant by psychiatric hospitals, meaning a psychiatric hospital could be a place you go for relatively short-term, what we now call stabilization, meaning something's really not going well, I'm not safe, I can't take care of myself, my family needs help taking care of me, and you're there for a few days or a week. But inpatient also used to mean being in a place for weeks or months, because we've always known in the field that depending on the illness, in some cases, one needs a longer stay away from home. Now, of course, you can imagine that a place you would stay weeks or months might not look the same as a place you stay only for a few days, right? For example, if you're not in any acute danger, you should be able to go to the gym or go to the pool or go for walks or even go on passes and go into town or go see your family at home,
Mhm.
right? That used to be part of what was called inpatient. And nowadays, and this is really more a terminology question than anything else, we've separated those out. That is, we generally don't call inpatient the place that you stay for longer. We call that residential. Residential is a new word. We didn't used to differentiate those. But here at Silver Hill right now, we talk about inpatient as the place that you stay on average a week. And
Mhm.
that is a more safe environment with nurses and people checking in on you regularly. And we call residential the place where you stay for a month or even longer, because what you really need is what we might now call in our general culture a wellness retreat, a
Mhm.
place to go and take care of ourselves and to get better. And those two places look quite a bit different. And so I want people to know that the word inpatient doesn't just explain everything, that differentiating between that shorter term inpatient and residential is also helpful.
And just backing up a drop, when we talk about inpatient versus outpatient, the patient, second part of both of those words, is either living in the community on their own, outpatient, or they're living in a facility with professionals, inpatient.
Right.
And then you further differentiate that by qualifying that when you reference inpatient, you're talking about that stabilization period. We're often medically, like with psychotropic medications, we're able to be more aggressive on an inpatient level with psychotropic medications and stabilize the person, experiment with the medication doses and the types more aggressively because we have round the clock medical care. Whereas if I were seeing the person once, twice, three times a week for individual therapy, we're going much slower because I don't live with the person and I don't know what's happening when they're outside of the office hour with me. And so when they're done being stabilized on medication and they continue their care, you're calling that residential treatment.
That's right. That's right. As long as the residential, they're still not at home. They're still
Correct.
staying here, but they're not in what you just really nicely described as this kind of 24/7 medical environment. They're in sort of an in-between space because frankly, one of the nice things about residential is that if you do have a crisis in the middle of the night, there are people around. So it's not that you're completely on your own. Um, but you're not in an environment that feels medical. In fact, all of our residential houses are houses. That is, you're literally staying in a house that a family once lived in,
Mhm.
and there's a living room and there's a kitchen, and it feels like you're in a bed and breakfast, and you're there, but you do have help available to you even in the middle of the night if you needed it.
So you have that added support of knowing that there are trained professionals. You're on a campus. You're on a contained campus. You're not having to think about your daily living activity responsibilities that you would if you were in your own home. You don't have to do your laundry. You don't have to figure out what you're going to have for breakfast, lunch, or dinner. The options are laid out there for you. And also, if you are in need of support outside of normal business hours, again, you're on a contained campus and there are professionals available. But
That's exactly right.
you're not getting 24/7 care the way you would in your inpatient setting.
Yeah. No, I think that's exactly right. I'll add one other, sort of maybe more nuanced aspect of this, which is, as you described it well, on the inpatient unit, what you really are getting 24/7 is a medical style care, right?
Mhm.
You have nurses and doctors available 24/7 to intervene with medications and in that kind of way. But one of the things that happens in the residential setting that I think is really, really crucial is you're in what I would call a therapeutic milieu. And what is a therapeutic milieu? A therapeutic milieu is a group of patients with therapists there, not nurses and doctors always, although there can be some, but therapist professionals who want to create an environment of healing where you're getting positive reinforcement, where you're getting advice about how to handle emotional storms, where your interactions with other people, while not controlled, you're actually encouraged to be in groups and to be doing activities with other people. But when they go awry, and they do sometimes,
Of
meaning you get
course.
into a conflict, you've got therapists there to help coach you through it and
Hmm.
help coach the group through it. And a therapeutic milieu is a really powerful tool. And many of our patients, after they've left, will say that of all the things we did, and that includes the medication, that includes the nursing, that includes the inpatient part, and includes the individual therapy, often the thing that they point to as the most helpful is their interactions with their peers in an overall supervised therapeutic setting. And to me, it's almost magical sometimes to watch patients really feel empowered and learn about themselves and end up leaving in a much better place than when they arrived.
Well, community is something that we are all lacking in our life right now and have been, increasingly in the last decade, I would say. So I can imagine how helpful that is. And I can also imagine how, if we're in our own community and we have an altercation with a loved one, or maybe not even a loved one, just a friend or a colleague, it is easy to dip out of that conversation and just have nothing to do with that person again. But what I hear you describing, I think, is that when you have this therapeutic milieu where there's licensed professionals that are on hand and witnessing some of what's happening, or at least hearing about it very shortly thereafter, they're able to encourage and support the individuals to perhaps repair and address those problems with a lot of support. And if you can do it there, maybe you can do it out in the community when you get there.
I think you said it so well, and I love that you brought in this question of what's going on even more widely in our society, because I think you're exactly right that we're suffering in many ways, and certainly COVID made this worse, but it was true to some extent, or has been true over decades. This loss of community, this
Mhm.
epidemic of loneliness, where people are
Yes.
much more on their own. And that's not how human beings were built to be. We were built to be social, to be in groups. And I think, not only do we crave that kind of togetherness?
Mhm.
But we're also, I think, in general, less good at sorting out some of the complexities of disagreements. And when we talk about the polarization in our society and the tendency to vilify other people and see ourselves as, very tightly within one group to the extent that we don't even want to talk to people in other groups,
Mhm.
I think that's not unrelated to some of the mental health difficulties we're having. In a therapeutic milieu, by definition, you're with other people, some of whom have different views than you do, and you now have the opportunity, with support from therapy professionals, to figure out how to manage that.
So tell me, how does Silver Hill differ from what we would generally think of? Imagine an inpatient psychiatric hospital. What's the difference between your facility and my local hospital that has a psych unit?
So I think the biggest difference is that as the world outside changed, and particularly in the 1980s and the 1990s, when managed care moved in and said psychiatric inpatient care had to look a certain way. And what they meant by that is it had to be super short term. It had to be essentially relatively inexpensive because hospitals had to be able to pay for it with managed care and insurance. Silver Hill said, we don't agree with all that, that there are things that you may be doing because you think they're good in terms of saving money, that aren't in the best interests of patients. And to be honest, in the long run, don't save money, because if you're not solving the problem, or you're confining people to a level of care that isn't the right for them, you're kicking the can down the road. You're pushing the problems off. But anyway, my point is that Silver Hill actually, in many ways, looks a lot like what good a good continuum of care looked like back 50 years ago. So what do I mean by that? which is when you're on the inpatient unit, you're getting super high quality, really good psychiatric care
Mhm.
that I think is still better than most, but probably not fundamentally different than what you see in other good hospitals. But here's where we differ the most. Very rarely do other hospitals have residential levels of care. When you
Mhm.
leave the inpatient unit, they send you home and you
Yep.
go into an outpatient level of care, which for some is great, but for some is not.
Right.
So what Silver Hill looks like in our residential side has become more and more unique because you are now moving from a hospital unit into a home, a house, where you
Mhm.
are living in what looks more like a bed and breakfast than anything else. And you are in regular supportive psychotherapy, seeing your psychiatrist regularly, participating in groups, socializing with other patients, people with similar issues, sometimes with different issues, doing wellness activities, going to the gym, swimming in the pool, going for walks or runs, doing other wellness activities like a group on art therapy or nutrition or some other way of feeling more human and good about
Yeah.
yourself. And I think, unfortunately, in our society, we've relegated a lot of those things to wellness, which is a perfectly fine name, but taken it out of good healthcare. And the
I
truth is,
couldn't
it's
agree more.
both.
I could not agree more. I really I just yesterday I was speaking with a colleague of mine who is not, a mental health professional, but a colleague in the wellness space who said, I really think I'm going to put together wellness retreats. Um and I want to put these retreats together for XYZ population and what do you think I need the most of? I said trained professionals. That is what you need. The paraprofessional, stop already. We need trained professionals. We need trained professionals who are trauma informed, who understand when they're getting in too deep and need to compartmentalize a conversation for someone else to complete because they don't have the training to handle that, so that the person who is on the retreat does not wind up paying the tab for you being, a cowboy with no restrictions because you're not in a profession that licenses and regulates you. That's what I think we need. And what you're describing is just that. I came of age. Uh, I graduated in 96 with my master's degree. And my first job was in a psychiatric outpatient program running a PHP and an IOP, partial hospitalization program and an inpatient, I mean,
Intensive.
an
Yeah.
intensive outpatient program for adolescents. That's where I cut my teeth as a new clinician. And I remember getting there week one, and my supervisor sat me down and said, "So, kid, I welcome to the field. Unfortunately, you missed the heyday when psychiatric care used to be amazing. Now we're run by managed care. We get them in, we get them out. That's it. We stabilize and then we send them right to you. So the inpatient unit is just going to medicate people, get them to the point where we consider them to be clinically stable, and then we're going to send them right to you." What that meant for me, forget the fact that I was a new clinician and I had no business being in charge of anything, let alone an intensive outpatient program or a partial hospitalization program, which are both very intense day treatment programs where the person lives at home at night. The What it meant for me is that I had to manage the care of people who were really barely stable, barely stable. And like, if you're only stable for a day, how do you know if you're going to revert? And in 2 days, need something more intense than what I can provide you. So the kind of patients that I was working with, the kids that I was working with, were often so much more symptomatic than they should have been to be in my level of care.
Yeah. No, listen, I have so the same experience you did. And it's sort of heartbreaking, right? Because you have people with excellent training who come out of training and they want to do the right thing and they're trained to do the right thing as you were. And then they find out that the system has changed and they realize that, wait a second, if I want to take care of people who have more serious, complex illness, and many of us did want that, then I have to accept all these compromises. I have to work in an environment where people are barely stable, or they
Mhm.
can't afford to pay more experienced supervisors or clinicians, or just as somebody seems to be getting better, this insurance says they won't pay for it anymore, and they get moved on to the next step. All the things that you're describing, and of course, that's a huge disincentive to work in those settings. So
Right.
you then end up, and I don't know if that place was lucky enough to keep you for a while, but I've seen a lot of really good early career clinicians do it for a couple of years and then they leave because they say, this isn't the environment that lets me do my best work and really grow, right? And then you ask, well, why are we having problems with turnover? Why are we having problems with, the number of clinicians who want to work in the field? It's not that we don't have people who are well trained and want to do it. It's that we're not supporting them and giving them the tools they need to do the kind of care that they feel good about. And I think you and I both know what that looks like and wish there was more of it.
Well, to that point, I lasted 2 years. Um, I was so burnt out at the end of 2 years. It's so funny. I have to remind myself that at age 28, because I graduated, I was 26. At age 28, I already felt burnt out. When I work with and supervise younger clinicians, or students, interns who are like, I feel like I'm burning out. And my knee jerk inclination is to internally roll my eyes. And I have to check myself and remind myself, no, you can burn out because when you don't have the calluses built up, when you don't have the skills built up, it takes a much greater toll on the individual. And we wind up losing a lot of people.
Yeah.
What happened to me was I wound up feeling so burnt out. I was so understaffed. I was running 4 programs. I was one person. I didn't even have my highest level of license yet. I was still
Right.
earning my license, the hours that it takes to be able to be a licensed therapist. And I was so exhausted from, trying to deliver a level of care that the institution did not provide me with the support of, but it wound up being my boot camp to teach me how to do it myself. And then I went off at 28 and I had the audacity, you know, to hang a shingle. And that's the practice I've been in ever since. There have been lots of lessons to learn along the way, particularly around the business side of things. But at the end of the day, what I want to provide is the highest level of care that people can access anywhere. I want to be the best I can humanly be. And in order to do that, I need downtime so I can be in the research, so I can be reading what the newest evidence based treatments are. And the reason, why I have turned to places like Silver Hill over the years is because I want my clients to get the same type of care that they're getting from me, no matter where I send them. Most people assume that to go inpatient, you have to be in a full blown crisis. Um, so help me understand, what kinds of patients do you actually treat? And how intense are their issues when they tend to reach out to you?
No, it's a great question. And I'll tell you the model that I generally use and that was taught to me earlier in my career, which is the way I think about it is at every stage of treatment, we recommend a higher level of care when the person isn't able to use the current level of care because of some other extenuating circumstance. So outpatient therapy, the absolute standard for the field, right? There is and should be more outpatient therapy than anything else. But any therapist knows that there is a point at which a patient isn't able to use outpatient therapy. So
Mhm.
what might some of the reasons for that be? So one example would be they're not safe, right? For me to treat a patient in an outpatient setting, I have to know that they will come back to their next session, meaning they won't
Correct.
hurt themselves, they won't hurt somebody else, they won't expose themselves to some kind of really scary risk, whether it be with substances, whether it be with self-harm, that would prevent them from coming back. I can't do my work
Mhm.
if I don't have a reasonable assurance that they can come back. So that's one. And so one of the not uncommon reasons that somebody would come in to an inpatient level of care is they weren't safe. And
Mhm.
often that looks like them having said to their outpatient therapist, I am so distressed. I am so depressed. I am so anxious. My thinking feels so confused that I can't commit to you that something bad wouldn't happen to me, that I wouldn't either hurt myself or take substances in a way that would ultimately be unsafe to me. So
Mhm.
that's one of the common reasons. Another reason would be they simply are unable to get to the sessions. And the most common reason for that is depression.
Mhm.
Imagine, and I hope most of your listeners don't have personal experience, but some will, being so depressed that you can't get out of bed, that you
Mhm.
can't make it to an appointment, that you can't turn your computer on and turn on Zoom even, right? If
Right,
you
because the
can't,
first technological glitch that you hit, it's the roadblock that makes you just roll over and put the
right.
covers over your head.
Right, exactly. So if you can't do that, then you need some kind of structure to help you get. Well, the first, it doesn't mean you necessarily have to go inpatient. Maybe you have somebody calls you and makes sure that you get to an intensive outpatient or a partial hospital or a residential. But sometimes when people are so unable to care for themselves or even get downstairs and make themselves breakfast, that's another reason that inpatient would be warranted. And then the last, well, I'll name two more reasons. One would be that you are so far down the path of addiction, so far down the path of using substances that to get through the day, you need to go and get a drink or get some other kind of drug to use, even when you know, and most people do at some level, that it's not a good thing for you, that it's going to be bad for you in
Mhm.
the long run, but you can't actually get through the day without it. You need to be in an environment where someone is helping support you through that. And sometimes that's interpersonal support, sometimes it's medication support. Some of these drugs, including alcohol or benzodiazepines, are dangerous to come off of. And if you have a regular habit, you can't stop cold turkey or something really bad could happen.
Right,
So
you
that's
certainly should not. The number of
correct.
times every month that I have to sit a young adult down and be like, um, "This is a medication you should not come off of on your own. You could have so many medical consequences, and you do not stop, like, and give yourself whiplash. You
Right,
titrate off it. You
right,
go very low and
right,
very slow off
right.
of your dose. You do not, I mean, but people don't know this.
No.
They don't know
And it,
this.
and it's complicated because different drugs have different names and have different half-lives. And so but you're 1,000% right. And then the last one, and it's probably the least common, but I say it because sadly it's gotten more common, particularly with the really high THC levels in current cannabis, is people who are no longer able to think in any kind of organized way. And the common name for it, I know it's a scary name, but it is the clinical name is psychosis. And we are seeing more and more young people who are using, cannabis in really high dose ways daily, whose thinking is really no longer organized. And that itself can be dangerous, even if they don't know it, because they can't make decisions that are safe for themselves. And all of those are reasons why one might need to come into an inpatient facility.
So
Yeah.
help me untangle some cognitive dissonances that are happening as we speak. Um, we have largely decriminalized THC. What are we seeing differently in the cannabis that is produced today, and how does that relate to psychosis?
So I think this is such an important question, and I think already you've used a word that's a really important one, because when we talk about legalizing marijuana, we're conflating two things that to me have very different values: decriminalization and commercialization. And let me
Mhm.
separate those. I happen to be a big believer that decriminalization is right. That is,
Mhm.
we should not be sending to jail or punishing people as if this were some kind of a moral failure who use cannabis, who use marijuana, right? We have disproportionately affected people in inner cities, people of color, people of low socioeconomic status, and used our criminal, and I think misused our criminal justice system to punish them for what is in many ways really more a medical and social issue. But let me tell you why that's different in my mind than commercialization. Commercialization says for-profit companies, go make as much money as you can by getting people, and it turns out mostly young people, to use more and more cannabis. We live in a capitalist society. In a capitalist society, we tell companies, greed is good, that it's okay to go out and make as much money as possible. But what we've unfortunately done in the states where we have legalized cannabis is not just decriminalized it, but we've written a little bit of a blank check for big companies to come in and make large profits at the expense of the brains of young people, because they're motivated to get as much THC into young people who then need it more and more, who need to spend more and more money, and in some cases, for the rest of their lives, are going to be using cannabis in this way. And I think that's unconscionable because brains are still developing. It's leading to higher rates of psychosis and other mental illness. It's causing all sorts of dysfunction to our society. I believe we should continue to decriminalize, but we should put structures and regulation around commercialization so that the way people use is responsible, that the concentrations are not toxic to their brains.
Correct.
And
Yeah, in much the same way we do with alcohol. There are
much the
caps
same way
on
we
how
do.
much alcohol can be, the alcohol content in every drink.
Yeah.
And so what I hear you saying, I recently interviewed the CEO of a THC company called 1906, and the CEO of that company makes micro doses, 2 milligram doses of THC. That many of the people that I have worked with over the years have used. They've been very effective. And one of the things that he said was the difference between a medicine and a poison is in the dosage. And is that what you're saying?
That's
That
beautifully said. I hadn't heard of them, but I think that's so true.
that at high doses it can induce psychosis?
That's absolutely true. And the evidence for that is really incontrovertible. That
Jesus.
THC at high doses induces psychosis. And it's not just a high dose of a single hit, it's how often you repeat it. So, there is individual variability. I'm not saying that for everybody that cutoff dose is the same. So I also think we have a responsibility to monitor and coach people. So, for example, if a dose that in one person actually is perfectly safe, but in another person induces psychosis, we need to be helping people identify that and not get into trouble, because the longer it goes on, and this is one of the tragic things about cannabis, is sometimes people use more because it actually, for them at least, it feels like it makes them feel better about the psychosis. So it's a vicious cycle. Now they're using more and they're getting even more psychotic.
And not everybody gets psychotic from
And
high
not
doses
everybody
of
gets like
THC.
correct.
Okay, just to clarify.
Yeah.
But is it the kind of thing where if somebody has a predisposition to psychosis then uses THC in a high dose, that combination is more likely to trigger a first break?
That is what we believe. And what I wish we could do, and we're not there yet, is to identify that vulnerability beforehand, because wouldn't it be amazing if actually we knew, and for some people said, listen, it is not safe for you to use over this concentration. And for somebody else will say, no, your tolerance is different. But we don't have any way to identify it. So we only can identify it in retrospect. But I think the way you said it is exactly right.
Yeah, yet. We don't have a way to identify it yet.
Correct.
We will. We will.
Right.
Prohibition certainly didn't help that.
Right.
We would know more about the drug if we didn't criminalize it the way we had.
Right.
But as somebody who grew up in the DARE program and during the war on drugs, and in recent decade and a half has, reorganized the way my brain understands that whole indoctrination, hearing that something as uh, seemingly benign as THC can induce a psychotic break, that went into my trash bin in my brain until just now. Now I'm understanding that very differently. Thank you for taking the time to explain that to me.
Yeah. And listen, I think the honest truth is there's still a lot we don't know. And what I wish we had done in the states that have moved towards legalization is collected that data in a systematic way. There is pretty good data coming out of Colorado now. It took a while, and Colorado's had legalized marijuana for a long time now, that rates of psychosis have gone up significantly. But in contrast, Connecticut, which is a state that decriminalized only recently, is not collecting that data, as far as I know. And I really think we should have done that, because I think then we're doing the responsible thing. We're making a change and we're monitoring how it affects people.
Well, I would imagine that there are different ways of measuring that retroactively. I mean, you can imagine you're a medical you're a
Yeah.
medical director. You can imagine the various ways we might like pull charts from a generalizable population, and then it's not it wouldn't anything we do is we're taking a sample and then we're studying it and we're making conclusions that we imagine are applicable to the general population. We can't possibly know every single person
Right.
who has a relationship between one variable and another. That's the way we measure things. But yeah, I hear what you're saying. If the states themselves would take the time
Yeah.
to record these things, it would be really helpful.
Right. And listen, I'll give you another example of how we could be doing this that I'm sure will make sense to you. By far, the organizations that have the best data about healthcare in this country are the insurance companies, right? We don't have a nationalized health plan. So if you really want to know the kinds of care people are getting, the most accurate data is held by the insurance companies, because they're the ones actually reimbursing for or paying for that care. But we do not have rules that force the insurance companies to share that data in careful, secure, de-identified ways with public health authorities, so that we can really track this stuff responsibly. I
Which is
believe we
terrible.
I believe we should. I believe that's part of the responsibility that they should have.
I absolutely agree with you. And I think that the insurance companies and the insurance lobby has way too much power in this country. It's part of why we don't have a single payer system,
That's
or
right.
a system that is more advantageous for all of the residents. I don't just talk about mental health. I live it. And in my 20s, I built a boutique private practice that reflects the kind of therapy I always needed. It's called Alternatives Counseling, and we are now accepting new clients. If you've ever listened to this podcast and thought, I wish I had someone to walk me through this in real life, that is exactly what we do. We work with individuals and couples, especially high achievers, who are killing it in their careers and want that same success in their personal lives. We help you build deeper, healthier connections without losing yourself in the process. This is evidence-based therapy delivered by licensed therapists who are the best of the best. Change is hard. Doing it alone is harder. Come do the work with us at alternativescounseling.com. I want to go back to what we were talking about a few minutes ago. I understand that people who go to Silver Hill might be people who struggle with addiction. I understand that they also might be individuals who are experiencing a thought disorder. They're having some psychosis. They're hearing voices that other people can't hear, or seeing things that other people can't see. What about the people in the middle? What is an average patient who's not experiencing one of those two things, either addiction or psychosis? What does that average person look like when they come to you? What are the challenges that they're coming up against? And why are they seeking inpatient hospitalization?
So, I think for the inpatient side, the three different places, and you named two of them: thought disorder, substance use, and addiction. The third one would be severe depression. People who are
Okay.
so depressed that they're not able to be safe. But let me broaden it a little bit because I think there is another big category that's less represented on the inpatient, but more represented in the residential setting.
Mhm.
And it probably even makes up a bigger proportion of our residential patients than the other three that we just named. And this category goes by a few different names, so bear with me a little bit. I'll start with
Sure.
the name that I think is probably the most accessible and actually doesn't feel pejorative, because sometimes in psychiatry we have this problem where the words we use end up sounding like labels or criticisms, which is not good. But the term I probably like the best is emotion dysregulation. And what is
Yeah.
emotion dysregulation? Kind of makes sense. It's that I'm not good for some reason at controlling the lows and highs. That is, I can be fine sometimes, but then I get into certain, and it's usually social interactions or
Mhm.
conflicts where my emotions get out of control. Now, you might say, well, isn't that bipolar disorder? And I'd said, well, not really. Bipolar disorder is a term that's been used in lots and lots of different ways. The original meaning of bipolar disorder was actually much more extreme. And I'm not talking about being fully manic, which is often a state of thought disorder, or fully depressed. I'll put that in those other categories. I'm talking about an in-between state where your emotions can range all over the place, even within, days or hours. And usually in the context of interpersonal stressors,
Yes.
and a lot of it to do with sense of self, identity. Who am I? What do I want to be? How do people think of me? Who cares about me? What relationships am I in? Now, the other term that gets used for this, and I intentionally left this name for later because it can make some people find it useful and some people find it a terrible term, and that's the term of personality disorder.
Mhm.
Now, do I like the idea that people would feel criticized about their personality? No. And if somebody feels criticized by that word, I don't use it. But for people who find that term helpful, what they tell you is if you look up a personality disorder, or particularly look up borderline personality disorder, it describes a state of emotional instability or emotion reactivity that at the
Mhm.
core is about not feeling secure in one's relationships and not feeling secure in one's sense of self. And we find that that's far more common in the world than people often realize. And that if you actually look for it, you see it to be fairly common, particularly in those folks who are not getting better in their individual psychotherapy. People
Mhm.
say, well, DBT is so great. Well, DBT was developed as a treatment for personality disorders. That's what it
Yeah.
was developed. And that's what's so, and by the way, I know I'm telling you things you already know, but I'm saying this to your audience. Um, so we have developed a lot of expertise in the treatment of these kinds of emotion dysregulation problems. And a majority of the patients I would say that we see in our residential programs have at least some symptoms along those lines. And we use both individual and group psychotherapy as well as medication as ways to help them get a handle on those difficulties and to leave with much more sense of ownership of their identity and control over their emotions.
And is it fair to say that a large cohort of people who meet criteria for borderline personality disorder or other personality disorders have a history of untreated trauma?
That's exactly right. The estimates are probably 80 to 90%. And the
So
only
when we
reason, yeah,
Right, so when we talk about personality disorders, which people do in both in our field and lay people
yeah.
take offense to or have a certain people have a knee-jerk reaction to that term, kids. Just look it up, okay? I'm not gonna go deep into it here because this is an elevated conversation and I wanna keep it that way. I've made it through like 40 minutes. I have not dropped one F-bomb. I have been so appropriate. And the nodding and the yes is because I'm hearing everything you're saying and I'm agreeing with it. And I want you to know that I'm agreeing with it. And I want them to know that I'm agreeing with it. And that's all the mutterings that you're hearing from you. I'm not intending whatsoever to imply that this is obvious. It's not. That's why you're here to open a door for the listeners that would otherwise not be available to them. But the reason why coming back to personality disorders often being rooted in a history of untreated trauma, that is also often the root of addiction, right?
Yeah.
And that is why it's so important that we include that cohort in the conversation because
Yeah.
really the addiction is just the symptom of a problem, as is the personality disorder.
Yeah. I think you're right. And I'm so glad you brought it up and really should have said it myself. I'll tell you though, the reason I often don't lead with it is because people are often in such different places in relationship to their trauma. And when somebody can come to us and say, hey, I know the root of the problem. I want to work on my trauma. That's fantastic. That means they're on the right path. And we can then engage with them around the trauma, which we do. We have multiple modalities that we work with trauma around the campus. A lot of our patients aren't there yet. A lot of our
I
patients
totally
come
can
to us
imagine that.
and that's not the thing. And you can even ask them very direct questions. Did you experience trauma growing up? Did you experience trauma in your life? Were you unsafe? And the answer is no, no, no. Because I think so many people are conditioned to not want to call things trauma or to not want to see themselves in that way. And it often is only weeks or even months later, as part of the treatment, that they're able
Right.
to identify these roots. So we want to be respectful of that. And I think that's again why I like the term emotion dysregulation. It is a symptom. And I want to be respectful of the different reasons that people have for getting there. But as you point out, in most cases, there is a traumatic root.
That's so interesting. As you're describing that, I was thinking to myself, how do I approach, because I teach emotional regulation skills all day, every day. It's imperative as a relationship therapist, as someone who's trying to make interpersonal relationships more harmonious. And I truly believe with every fiber of my being that emotional regulation skills are skills that can be taught and should be taught. And many of us, we all learn relationship skills one way or another. The extent to which we learn poor ones will result in emotional dysregulation. And those of us who have had modeled for us more ideal responses to emotional dysregulation result in, we tend to be more resilient than other people. So when I'm hearing you talk about that, I'm vacillating between, so what do you treat first? Do you treat somebody with the DBT skills or do you treat the root of the trauma? But it makes sense to me that you would give coping skills because to treat the trauma can be dysregulating and you need the person to be able to tolerate that process.
But I think you answered that question exactly right, which is you follow their lead, and their lead tells you what they're ready for. And if a patient has the emotion regulation skills to get into the trauma treatment, that's great, right? I think on the residential side, or certainly the inpatient side, more likely we see people who don't have those skills yet. So we
Mhm.
use our time with them to build up their resilience, to build up their skills with the hope and the plan that then they can go on and in many cases use that to face their trauma. And that it does tend to be what we see. So there's all sorts of interesting models of how one treats trauma, and they all start with that creating that sense of safety so that you can go down that path.
So Silver Hill provides DBT therapy. Does it also provide some evidence-based trauma treatment like EMDR or
It's interesting. We don't do EMDR because, in our experience, by the time they're ready for EMDR, they don't need to be residential. So they'll often do EMDR after they leave here. But in addition to DBT, we do a number of other modalities, both for emotion dysregulation and for trauma, that we can do and they are ready for. So, to give you some examples, one of them is we do what's called cognitive processing therapy, or CPT, which is an evidence based therapy for trauma that we feel they are ready for in our space. We actually have a program specifically for people with dissociative disorders. People may know that one of the responses to severe trauma is to dissociate, is to literally have the experience of your mind leaving your body. It sounds really dramatic, but it's far more common than I think most people realize. And in its extreme versions, it has other names. And I think sometimes people get put off by this concept of a dissociative identity disorder. That's a very extreme version. But we treat people with dissociation all the time here. And we also do a range of what I would call more exploratory therapies around both trauma and motion dysregulation. So, for example, something called mentalization-based therapy, or MBT, which was originally developed in London and is now being done all over the world. which shares certain elements in common with DBT. It's very good at helping people manage in a practical way, but it does more so, I think, even than DBT, get into some of the roots and really emphasizes our ability to understand each other's minds. Because, when you think about why is trauma so horrific? Why is trauma so disabling? Yes, there's an element of my physiologic response, and I think there's been a lot of emphasis, and it kind of makes sense that I have a physiologic response to a trauma. But the other place is because it makes other people's minds dangerous. And particularly when you have trauma that occurred in the context of a trusting relationship, whether that be a parent, a caregiver, a domestic partner, you can certainly understand why you would emerge from that trauma not able to trust people, not able to think about other people's experiences. But the problem is, even outside of that trauma, you're now impaired because we
Yes.
all need to understand each other's and to trust each other. So if we can use therapy, and MBT, I think, is particularly good at this, to help people understand other people's minds and understand their own mind, that's a very powerful tool for regulating their emotions and dealing with the underlying trauma.
So is what you mean that when we emerge from a traumatic event, it can often shape our worldview and skew it in such a way that we look at other people as being untrustworthy and dangerous. And then that informs, once even like decades after the traumatic event, how we interact with each other, or how we engage with others in interpersonal relationships. And so it's important to begin from a place of repairing because to be in an interpersonal relationship, we have to be able to take one another's perspectives. We have to be able to put ourselves in other people's shoes. That's the essence of empathy. Um, and that is the essence of being attuned to anyone that we care about or that cares about us, but that gets wounded in trauma. So this type of therapy that you're referencing, what is it called? MBT?
MBT, or mentalization-based therapy, and it's another one of the evidence-based. Probably the most evidence in the whole field for emotion dysregulation is DBT, but
Mhm.
MBT, I would say, is a close second. And
Interesting.
I think we're seeing it more and more, not necessarily used instead of DBT, but what we do is we actually use them together, and we find ways. But listen, I think your description before is right. And I love what you said about relationships, because the essence of relationships is that give and take. There's a phrase that I've always loved that emerged from a psychologist, who was at the New School in New York, called rupture and repair. And the,
Mm.
the concept behind this is that in most really good therapies, there's a process of getting into some kind of disagreement and then repairing it. And when you
With
think
the
about it,
therapist.
with the therapist. And when you think about it, that's what we need to do in our relationships too. I've never heard of a close friendship or a romantic relationship or marriage or anything that didn't have a fight, right? And the question isn't, do you have a fight or not? The question is, what do you do as a result of that? Do you have a way of repairing it with one another? And I think it is much more likely in individuals who've had a trauma history or who have emotion regulation problems to not be able to repair because it's too
Right.
dangerous. And
Mhm.
what MBT and DBT as well teach patients is how to develop that muscle around that.
And does it also teach the therapist the imperative to sort of set up that expectation that ruptures happen in every relationship, and
Yes.
when I hurt you, it will be
Right.
unintentional.
Right.
If we work together long enough, it's bound to happen, and when it happens, I need you to tell me so I
Yeah.
can
Yeah.
show you what an appropriate repair looks like because I care about you enough to want to do that.
Right. I think every therapist should say what you just said. And my experience, and I would imagine yours is too, having said that to many patients over the years, is that, patients will intellectually get it, but when it happens in the real moment, particularly in someone who has a trauma history, you forget, right? It's so painful. It is such a physiologic response to conflict that it's hard to move on. And a lot of the learning, I would say most of the learning that we do in psychotherapy is not just intellectual. It may start intellectually, but it ends up being about practicing it.
Yeah.
I make this comparison with our patients all the time that it's like learning to play tennis. And I say this not as a good tennis player, but right, you could read a book about tennis, you could watch a video about tennis, and you could know all the intellectual things in the world about how to hold the racket and where to stand and how hard to hit the ball. And it's not really that valuable. What's really valuable is to stand on the court with your tennis teacher on the other side, and the ball gets hit to you. And the first time you hit it in the wrong way, or you grip the racket wrong, or you put your feet in the wrong place, they teach you how to do it differently. And you practice and you practice, and eventually it becomes second nature. And that's the same thing we do in therapy all the time. So you got to practice, and that takes time, and it takes patience, and it takes a really good and trusting relationship with your therapist, because otherwise you're not going to come back for the next lesson.
Yeah.
So I to me, that's a way I try to explain to people what it is we're trying to accomplish.
And since we have a good amount of therapists that listen to this podcast, I just want to call out that, setting the frame for that, like telling your patient, your client, hey, I am at some point going to unintentionally hurt you. I need you to tell me when that happens so I can repair this. It's not just important for you and me, it's important for you to have that experience so you can then know how to do it with someone else. There's a ripple
Yeah.
effect that comes from that. My clients remember me telling them that,
Good.
and they almost always tell me. And in the beginning, it really sucked so much to be on the receiving end of that because I don't like to make mistakes. But I have learned more from myself, more about myself from my clients being courageous enough to tell me when I mess up than I have from every other person in my love life. Every other person, and I am married to a shrink, and I have very strong women in my life who have feelings. And I'm telling you, nobody has taught me more than my clients for being willing to tell me in the moment when I fuck up. It's so important. And not only have I been able to then repair this between me and the client, but I learned something about myself and I'm less likely to repeat it in the future. And the biggest takeaway I want therapists to hear is it gets easier over time to hear how you hurt someone, because what you learn over years of hearing this stuff is that often it's really not about me. It's about the client's history. And the thing I said that hurt my client wouldn't have hurt 5 other clients.
Right.
But all that matters is that it hurt the one client in front of me.
Right.
And so I can take it less personally.
Right. But I want to also point out something you did, which is really artful, and for me at least took, decades, and I'm still working on it, is this concept that it can be both at the same time. Yes, in some ways one might say it's inevitable that part of our job as therapists is at some point for our patients to be unhappy with us. And on some level, that's not our fault, but it is still a fuck up, meaning we still did something insensitive.
Yeah.
And they're both true. Because if we sit back as therapists and say, I never do anything wrong, I just said the same good things to everybody, and some of them take offense, not my fault. Nobody wants to talk to us if that's the way we act. We have to take responsibility. And it is a mess up because in that moment, we were being insensitive. We
Right.
missed something. And it's sometimes something because it wasn't true in our lives, or we were tired, or we weren't listening well enough.
Yep.
But how can it both simultaneously be a sign of our own failure and something that we model as, you know what, I'm not perfect and I do screw up, but I can own that and I can use it within my work with my patients to help it be a growth moment for both of us. I think that's what you said, but I just want to point out how that's a subtle concept that not everybody learns in their training.
Right. Thank you for clarifying that, because the part of my ego that really wants to be perfect sometimes has to say on the inside, I have a monologue that says, listen, you've said the same thing to 3 people. Nobody else has been hurt by this. It's my way of fuel injecting my ability to lean into that hard conversation without feeling like a complete failure. And also I said something insensitive or I missed something or I did something.
Because listen, our job as
I'm a
humans is not-
human.
Right.
I'm a human being.
Our job as humans is not to say the same thing to everybody. Our job is to is to tailor what we say based on it's about effect, not just intent. And I
That's
say, well, I didn't
so
mean it,
that's deep. No, you can't do that because
but you
that's what
can't
everyone
do
out
that.
there does that. Everyone in
Right,
this client's life does that.
right,
I didn't
right,
mean it.
right.
Yeah, I just had an experience yesterday where somebody was like, whoa, that felt like a dig. The last thing on earth I ever want to do is dig on a client. Last thing.
Yeah.
I want peace on earth. I sell love. That is what I am trying to foster in the world. So at first, my response was, oh, I didn't. And then I literally said out loud, I was like, let me not defend myself and hear how that made you feel. Okay. And I heard. And you know, we have to be able to hear it. And if we don't, we're really recreating for our clients the same experiences that got them to us.
Yeah.
We have to
And,
be better.
and I want to go back to something you said earlier, which I really liked. And I think to me, this is such an example. I think and we do it as therapists too. There's sometimes a kind of sleight of hand, like good therapists are like good friends, right? They care about you, they listen to you. And I think there is a lot about good therapists that are like friends. But sometimes that gets misheard as anybody can be a therapist. You don't need a lot of experience or training. But the thing you're describing right now, man, is that hard to do, right? You need training, you need experience, and you're still going to get it wrong. And that's why I still get supervision, even though I've been doing this for 30 years, right?
Ditto, me too.
Right?
30 years, still pay for consultation and
Right.
supervision anytime I hit even the easiest
Right.
roadblock.
So when people tell me that you could be as good a therapist after 1 year of training versus after doing it for 30 years, I say, listen, it's not to say there aren't great therapists who are early in their career, but experience does matter, particularly
really
with
does.
really tough patients. And I don't want us to undervalue how much it matters to have all those years.
Yeah. I have referred patients to you at Silver Hill over the years who don't meet the typical inpatient criteria. They weren't suicidal or homicidal, but they definitely needed more than outpatient care. I have also told my wife that if I ever find myself on the brink of a breakdown in the mental realm, she is to send me to Silver Hill. So, how do you treat people who don't meet the danger to self or others threshold but are still unraveling? Like in my worst nightmare, I imagine a level of burnout that no amount of vacation allows me to come back from.
Yeah. So listen, I think the first question is, would you be eligible for residential? Because I think in our residential setting, which is, inpatient by the old definition, not necessarily by the new definition, we have patients exactly like what you're describing, who are so burnt out. They're not a danger to self or other. They're not psychotic. They're not withdrawing from a substance. And they can come into a residential house and be in therapy, individual therapy and in groups and be in a therapeutic milieu and do extremely well. So I think that would be probably the first question. Now, if you say, you know what, they can't even take advantage of residential, they are so struggling right now that they need to be on the inpatient unit, I would say, okay, that can happen. It's a little less common, but usually that's because we need to give them the support they need. And sometimes it's a few days of just stability. Sometimes it is a medication adjustment. Sometimes it's something else. And let's get them ready for being able to take advantage of other kinds of treatment, like in residential or even in outpatient. But that's really kind of, to me, what the picture looks like. I do think in the long run in our society, we're going to need a certain number, just to take care of our population, a certain number of inpatient beds of really the most acute people. But we definitely need more residential beds because I think there is a large number of people out there who don't necessarily need to be inpatient, but who aren't getting better from outpatient services that could really benefit from this middle level. And what's sad for me is that right now, at least, we have a healthcare system that makes it very, very difficult to get that paid for. And I think we should be putting more resources into it.
So, when people are in the residential program, is the number of sessions per week, is it across the board generalized or is it individualized to each patient?
It's individualized, but there's certain standards. So, for example, in all our residential programs, you get at least twice a week of individual psychotherapy, at least once a week of a psychiatrist, and at least 9 times a week of a group. but sometimes it's actually quite a bit more than that.
Mhm.
And there are times when a patient might see their therapist close to every day. They might see their psychiatrist
Mhm.
multiple days in a row because they're figuring something out. Family work, for example, is tailored to the individual. Some people come in and they want their families very involved, and we think that's wonderful because they need it. Some people not so much, and they say, you know what, I don't want to have my family involved right now, and we tailor that to them. So there's kind of a minimum, which is still pretty intense, but then we build up from there.
And since you mentioned the fact that this should be covered through insurance and often isn't, is any portion of this covered through insurance?
One of the things we do, we're a nonprofit, and so we take essentially the money people pay us, and we use it either to pay directly our staff or to essentially invest back in getting better care for people. So we do that in a couple different ways. One is we have been engaged in a battle, to be honest, with the insurance companies about getting better reimbursement. And this is an area that's particularly interesting for me. People may not be aware, but there's a federal law in this country since 2008 that's called the parity
Parity.
law. That's right. And parity says you cannot discriminate against mental illness by putting obstacles in place that are not things you would do for physical illness. And by the way, nobody tolerates it if you've got a broken arm or cancer, right? But somehow we let the insurance companies get away with failing to reimburse for evidence-based medically necessary treatments like residential treatment. So, unfortunately, the parity law, when it was passed, they didn't have the political strength at the time to put enforcement. So, the insurance companies are breaking the law every day. And we so far have not been able to really get penalties against them. There have been some selective cases around the country, and Connecticut, and I'm very proud to have been very involved in this, just passed a law that holds the insurance companies in the state of Connecticut responsible for enforcing parity, for providing data to let us test that, and penalties in the insurance department if they don't. So we're part of that, and we are already starting to see some results. So since last year, we're doing these things in parallel. We are now making it very easy for our patients to apply for what's called out-of-network reimbursement for residential.
Mhm.
Unfortunately, they still have to pay up front, but we are seeing, because the insurance companies are a little scared of the new enforcement rules, we're seeing them reimburse sometimes 50%, sometimes as much as 80% of the cost of residential.
Wow, that's
And
amazing.
and if we continue to have success, we would ultimately like to be in network, meaning that the patients wouldn't have to pay the bill at all. In fact, we got our first in-network contract just a few weeks ago for adolescents, and we got an insurance company. And I wish I could say it's because they're the goodness of their heart, but because they're scared of getting in trouble with the state, we got them to pay a fair rate for inpatient adolescent treatment. And ultimately, my hope is we get to a place here at Silver Hill and around the country where insurance companies pay fairly and for good treaters with experience, with the right kind of credentials to do residential treatment for all.
That is outstanding to hear because I could have an entire other episode. It's for another day, not for this one, on the black hole of trying to advocate for patients and clients with their insurance companies. I give my client, I'm out of network, I'm not in network, and I'm on the higher end of the pay spectrum. I give my potential patients the questions to ask their insurance company, and I cover every box that one could check. And even with those answers, they're so cryptic in what they will tell the patient so that the patient knows what their financial responsibility is going to be for the duration of this relationship with me. And it's just such a basic question that one should have complete transparency about at the onset of engaging a therapist. My therapist is out of network. I have out of network benefits. How much should I expect to be responsible for after I meet my calendar year deductible? It seems so basic, but
Right.
they make it so veiled. And then when my client finally hits their crazy deductible, they're getting reimbursed dimes on the dollar, dimes on the dollar for what they thought was going to
Yeah.
be a way different price
Yeah.
point, and it's so
Yeah.
frustrating.
And I guarantee you that those companies are violating parity law, because all the things you just described are, according to parity law, a violation, but we're not holding them accountable. I've been involved in a project which I'm really, really excited about. It just got launched in Illinois, and I would love to bring it to New York and Connecticut and other states, where a nonpartisan company is preparing what's called an insurance plan scorecard, and this a parity scorecard, and it shows in stark detail which plans are red, yellow, and green. And I think every single insurance plan should be rated on these, so that before you go work for a company, or before a boss decides on which plan, or before you buy a plan in the marketplace, you know
Yes.
what their record is. But right now there's no accountability. And I hope as that changes, consumers make more informed decisions, and insurance companies, which by the way are for-profit, very profitable businesses, many of make billions of dollars a year, that they are held accountable for this.
Right. And then they argue that they should pay Medicaid plus 10% rates on therapists that have been in the field 30 years, with advanced degrees beyond what our
Yeah.
license requires, in a zip code
Right.
because and they're making the rates themselves.
Yeah.
They're like my next door neighbor, and they don't have any qualms about charging market rate. I would like to pay them Medicaid plus 10%. Let's see how
And-
effective their
And by the
company is.
way, see if they try to do that for your orthopedic surgeon or your oncologist. They wouldn't dare. So that's such a double standard that to get, well-qualified orthopedic surgeons, they'll pay much higher rates. And there's actually good data, there's been good research on this, that in mental health, those rates are so much lower in relation to Medicaid and Medicare than they are in other non-psychiatric fields. And that's stigma. That's taking advantage of the fact that as a country, even though we're improving, we are still scared of talking about people in our lives or ourselves having mental illness, and fighting back and saying this is not fair.
So good. It really is. For people listening who might be wondering, is this for me? Is inpatient for me? Would residential treatment be for me? What should they be thinking through? What are the signs that level of care might actually be the next right step?
Yeah. Listen, I think the first question to ask is the treatment you're currently in helping you as much as it could? And if the answer is, hey, listen, I am getting better, and I have a good therapist, and I have a good psychiatrist, and I'm progressing it as quickly as I feel that I can, then, I think you're in good shape. You don't need to look for a magic bullet. You're in the right place. Good treatment can take time. But if you're feeling like, I don't think I'm progressing as fast as I can, my next suggestion is talk to your therapist and psychiatrist about this and find out from their perspective why. Because sometimes the answer is, well, we didn't try this thing, or, you know what, I'm not specialized in this area, and you came to me because I thought we were working on one thing, but it turns out it's really something a little different, and you need someone more specialized in this area. And then there's other options as an outpatient. But if the answer you come to either by yourself or is with your therapist, that this intensity of treatment isn't enough for me, that I need something to really hold me at a higher level, then I think exploring residential or inpatient is worth doing. Particularly if you feel like you're stuck. If you feel like I'm not getting better at all because it's too dangerous and I can't get to my sessions and I can't actually try the medications that I'd like to try because I'm too worried about, being closely monitored and the side effects might be and so on. That's the time I would say, raise the issue. Raise it with someone you trust. Do you think a higher level of care would be helpful to me? And then, frankly, you can call us. You can call Silver Hill and talk to one of our admissions clinicians who are super well trained and they do this for a living. And you explain what's going on. And listen, we'll be the first ones to tell you if we think that, listen, there are other things you haven't tried as an outpatient, and you don't need this level of care. But if we think that you've tried the other things and to get better, coming inpatient or residential is going to be helpful to you, then we'll tell you that as well, and we'll see how it goes.
Where can people learn more about Silver Hill?
You can come to our website, silverhillhospital.org, or you can call our 800 number, which I'm about to tell you. It is 866-542-4455. And not only is there a number there, but you can click on the link and put in a question. There's a web form and all that other good stuff. It's all super confidential. And listen, we've been around for 94 years because this need is there, and we offer really, really high quality care. We're super proud of that. We want there to be more places like that. We do lots of education. Let me add one other thing. You asked me earlier on about insurance, but we also have what we call patient financial aid, and people can apply for scholarships and sometimes get up to 90% of the fees on our residential side off. By the way, our inpatient is covered by insurance, so that part we do take insurance. Even though the rates aren't great, we subsidize it, so there's no charge for patients. The residential is this kind of fee for service, like you said, out of network. Although we just launched our first adolescent plan and hope to do more of that in the future to make this affordable for as many people as possible.
Well, I have, jokingly said to loved ones, we got to start the Silver Hill, the fund for my bed, because at some point that may become necessary for just a month or two. Who doesn't want a little sabbatical of mental health? Also, I fantasize about going to Silver Hill for a solid month and a half. I have no shame about that. It sounds delightful. A campus with a pool and all these recreational activities. It's like adult camp with a therapist.
Totally. And if it's any consolation, all of our senior leaders, myself included, have said the same thing and said, "Save me a bed because I'm going to need it." And we don't say that to be cynical. We say that because this is the kind of care we want for our loved ones, for ourselves, and we're all human beings. And I think most of us who've gone into the field, myself included, went in because we've had our own struggles at times and we know what it feels like. And we think everybody deserves good care. So it shouldn't be hard to find.
Dr. Andrew Gerber, this has been amazing. Thanks so much for your generosity today. I really appreciate it.
My pleasure. What a fun conversation, Darcy. I really, really enjoyed it, and hope you'll invite me back sometime and we can talk more about any one of these topics.
We Need to Talk with Dr. Darcy Sterling is a Sterling Standard production. Editing and sound engineering is by Bart Megal. Our theme music is by Trending Music. Special thanks to Amanda Cristiani, Robin Gentian, and Inez Gut. If you're watching on YouTube and you got something out of this that was valuable, please do me a solid and like the video and subscribe to the channel. It helps more than you can know. We'll be back on Tuesday with another episode packed with the dating, relationship, and mental health hacks that you, my friend, have come to expect. References are always linked in the show notes. I will see you soon.